Good morning, everybody. This is Massimo Leone, Director of the Center for Religious Studies at the Bruno Kessler Foundation. Today, we have the great pleasure to receive a scholar, Dr. Fabian Winiger, who is a Senior Research Fellow at the Professorship for Spiritual Care within the Faculty of Theology and the Study of Religions at the University of Zurich. He's a trained medical anthropologist and holds a Master of Science from Oxford University, as well as a PhD from Hong Kong University. His research focuses on spiritual care as an integral, evidence-based aspect of patient-centered care. His main research interests include the digitalization of spiritual care and the role of religion and spirituality in global health and multilateral organizations. He is the co-founder of the telechaplaincy community of practice and the MEET Lab, MEET, and is also the author of numerous scientific publications and monographs, as well as the leader of international projects funded by the Swiss National Science Foundation and also the John Templeton Foundation. So we thank you, Professor Winiger, very much for joining us today, and I'll give you immediately the floor for a talk in our seminar, whose title, the title of your talk will be Unplugged, How Spiritual Care Providers Address Professional Isolation and Patient Loneliness in Digital Healthcare Settings. Thank you very much, Professor Winiger.
Yes, thank you so much for your invitation to present to your cycle of seminars. It's really a pleasure. I regret not being able to come to Trento today. I was just in Rome at the URE for a week, and I just wasn't able to make it, but I'm very happy to be here remotely, and I'm glad there's quite a few of you joining remotely as well. So thank you for this wonderful opportunity. I hope to visit in person one day. So I'll be talking about the connection really between spirituality, health, and digitalization, and also in the context of your cycle and the theme of your cycle. Also, I'll be touching on this topic of solitude and loneliness. And you will get a good insight into the work I'm doing at the University Research Parity Project on digital religions, of which Accursio is also a part. And also you will get an insight into spiritual care, what it is, what this professional field does in terms of research and practice. And yes, I really look forward to the discussion as well. So as it's been said, my name is Fabian Winiger. I'm a medical anthropologist at the Professorship for Spiritual Care at the University of Zurich. There are not many professorships for spiritual care. This is a relatively young field of research and practice, and one of these professorships is at the University of Zurich. So you may be wondering about this title of my presentation. What do I mean by unplugged? So by unplugged, I mean a metaphor for being disconnected from ourselves and from others. So in a digital context, if a device is unplugged, or if a device is plugged into the internet, I should say, the person who uses the device is also connected to the internet, and vice versa. If it is unplugged, this person is disconnected really from most aspects of their lives, right? Including their social lives. So this connection, or being unplugged from the internet, really can lead to aloneness, and which also is the theme of this seminar cycle. So in the context of spiritual care, being unplugged could be described as a patient or a spiritual care provider who lacks the opportunity to connect with the other part of the spiritual care receiver or other actors in a care setting or in a digital setting where care takes place. And as you will see in the following presentation, there are many places and ways in which spiritual care providers and receivers, that is usually patients, are plugged in or not plugged in, and many more places where there is no such connection, and there is in fact isolation of patients and also spiritual care providers in healthcare, and specifically in digital healthcare settings. So I'd like to give you first a brief introduction of this term spiritual care and what I mean by it. And I will then talk about digital health in a few words to set the stage of the remainder of my talk. And then I'll say a few things about solitude and loneliness and how this relates to digital health. And then I will turn to digital spiritual care, which we could really describe as a subfield of spiritual care, which plugs into digital health, so to speak. And I will then move on to two studies which I conducted on this topic, one on how the population accepts forms of digital spiritual care, and another on how on the role of AI in spiritual care. And then in the end, I will talk a bit more about professional isolation, or as I said, what happens when spiritual care professionals are not plugged into the healthcare system and its digital infrastructures. So spiritual care, what does this mean? So for those of you who may be new to this term, spiritual care is really a field of research and practice which supports holistic, patient-centered healthcare. And it does so by attending to the mental, the emotional, and the existential needs of patients, and also patients' relatives and their caregivers as well. So any healthcare professional can offer spiritual care, but there are specialists who are people specifically trained to do spiritual care. This is all they do. And they're usually called healthcare chaplains. And they may be, but they are not always clergy or priests. Traditionally, they were clergies and priests, but this is changing. Then there are also spiritual care generalists. So these may be doctors or nurses, and they may provide a form of spiritual care as part of their ordinary practice. So you may have a palliative care physician who at a basic level can deal with people's existential struggles and needs in a way, and also refer the patient to a specialist when this patient really has, for example, a deep crisis, a deep existential crisis. These experiences are very common in healthcare. So either way, whether you are a spiritual care specialist, that is a chaplain, or you are a spiritual care generalist, that is any other healthcare professional, particularly in palliative care, in any case, spiritual care is usually delivered in an interprofessional team that looks after the patient as a whole person. So you can see here on this photo a chaplain and a team of healthcare professions, of physicians and nurses. And this particular photo is at the University Hospital in Zurich in Switzerland. So you may ask, what do these providers actually do, spiritual care providers? What is it actually that they do? And so in short, again, they help people deal with grief, loss, and existential questions. And these are very common companions to serious illness and also to accident, and specifically in the process of dying. So spiritual care providers help teams and patients and also relatives make decisions which fit the patient's values. And they also try to offer support that fits the patient's culture and beliefs, so it is culturally appropriate, and really whatever those beliefs happen to be. So it is not about the spiritual care provider's own beliefs. It is not about their religious mission or being sent by their religious community to bring something to the patient. It is more in healthcare system really about the patient's needs. It is a very patient-centered paradigm. So what do they do in more detail? I want to make this a bit more concrete using a recent scoping review of what chaplains do in practice. And this scoping review is really wonderful. You can see the citation in the bottom. It has a huge list of tasks, and it is too much to fit on a slide. So I just took the headings of these tasks, and you can see here, these already are 2 columns of tasks, just the headings, just the categories. And some of this is what you might expect. So spiritual care providers may offer prayer or pray with patients. They may conduct rituals or help or facilitate patients, families, or caregivers do rituals. They may support with grief and bereavement. So this is really what confessional pastoral care has traditionally focused on most strongly. But there's also much more. So spiritual care providers sit with families through hard decisions. They mediate conflicts. They advise and help with ethics consultations. They connect people to their own communities. They support the staff themselves. They do many tasks, including also conflict management, advocacy and communication, advanced care planning, generative documents. So when a person is dying, maybe they want to leave something behind for their children, which may not be a will in terms of a material inheritance, but a spiritual will, so to speak, a spiritual inheritance, something to leave behind, to pass on, to tell to their loved ones, which they want to communicate. So there are many things spiritual care providers do, and they can be very busy. So why would we need such a profession? As we know, there are people, our healthcare systems are saving money everywhere. You may say even life-saving aspects or clinical specialties are seeing funding reductions or struggles. So you may ask, well, why do we need such a profession? Isn't this like a luxury? But actually, spiritual care really contributes directly to the goals of healthcare. So it really has an impact on the triple aim of public health, which is improving the patient's experience of care, improving population health, and reducing the cost of care as well. So spiritual care, if it's done properly, it really makes a really major contribution to the quality of healthcare, and we are really lucky to live in a society where this is quite widely recognized, that the patient does not only have physical ailments or an illness, but is really a complete person, which also seeks meaning and tries to make meaning of their life, and that this is really a part of health, which cannot be ignored. So there's a recent study by White et al. Published just very recently in the Journal of Healthcare Management, and this used data from the US Center for Medicare/Medicaid Services to examine urban adult acute care hospitals between 2015 and 2019 to find out whether having a chaplaincy department impacted patient experience scores, so how patients rate the quality of care they receive. And it really found that hospitals with chaplaincy departments reported higher hospital consumer assessments of healthcare providers and their systems, and also were higher for patients to recommend the hospital. So it really makes a big difference to patients as well, if they are cared for as a person and not just as a body. But there's this line here from Viktor Frankl, and it really captures better than any other statistic what spiritual care can do. So those who have a why to live can bear almost anyhow. So very unwell people try to make sense of what is happening to them. Why is this happening to me? Is it my fault? Am I being punished? Or caregivers also wonder, have I done the most I could do? Should I have done this? I need to come to inner peace. I need to find a resolution on this or that. People are constantly trying to make meaning of their lives, especially in crisis situations and especially in situations when life circumstances suddenly change. For example, if someone has an accident and suddenly they cannot walk anymore. So the way they give meaning to their lives really has to change, or they will have a really, really big existential crisis, which is so big that the medical treatment itself, in a way, is meaningless to them. So when someone has a reason to keep going, they can really carry a huge amount of pain and uncertainty, and can even learn to find happiness and fulfillment in a life in which they may not be able to do certain things anymore. And they may find, rediscover this meaning of a changed life, or even find a deeper sense of meaning which they didn't have before they had an illness or an accident. So yes, patients are often in deeply existential crisis situations in which they ask for the meaning and purpose of their life. And with Paul Tillich's correlational method, you could argue, for example, that spirituality is one potential answer to these existential situations. There are other answers also to these existential situations. Spirituality is one of them, and spiritual care providers help patients find their answers, help them make meaning of their situations. There's also a difference to psychology and psychiatry. So often people say, well, isn't this something a psychiatrist or a psychologist should do? What's the difference to mental health? There's a few big differences. So for a start, psychologists and psychiatrists are interested in diagnosis, pathology, and treatment, right? So usually going to a psychologist, clinical psychologist or psychiatrist means you want to a treatment or a cure or healing for a specific problem, which has a diagnosis, has a name, which can be identified and can be treated in a way that the body can be treated. Spiritual care works a bit differently. Spiritual care also seeks to achieve clinically relevant outcomes, but it is not so much pathology focused. So when a patient has an existential crisis, this is not pathological. This is normal for anyone who has profound changes in their lives related to illness or accident. It is normal to have an existential experience or even a crisis. This doesn't have to be pathological. It can also be actually a positive thing. So spiritual care providers don't pathologize generally. They help people in a very resource and process-oriented way, which is salutinogenic. So it focuses on the person's resources to help them get better rather than trying to fix a pathology. The other big difference is also that spiritual care is interested in the meaning of life, whereas mental health disciplines often are interested in the meaning in life, right? So both is important, but again, in existential situations, the meaning of life is really what patients can struggle with. So there's real demand for spiritual care in society. There's a representative survey, population survey we did in Switzerland, in which almost half of the population, 49.3%, said that they want spiritual and religious aspects to be included in their healthcare during a hospital stay. Across Switzerland, 39.8% of people report having had contact with spiritual care at least once, and 14.9% have had contact in a healthcare setting. So a hospital, a nursing home, a psychiatric clinic, rehabilitation clinic, and so on. So let's have a look at digital health then. So digitalization is a very important topic for spiritual care. And the reason for that is it is a very important topic for healthcare in general. So you can see here some images which show how far digitalization has come. This is in parts of the United States. So you can see almost like a command center in the middle here at Intermountain Healthcare in St. Murray in Utah. And it looks like an air traffic control more than a hospital ward, right? You can also see care delivered in the left and the right, really through screens. So traditionally, of course, patients, physicians, they did rounds, they still do rounds in the hospital ward, but more and more patients are being discharged and treated at home in ambulatory care. So the time that patient spends in hospital is reducing. It has reduced very much in the past 50, 60 years. So now, even if you have a very invasive surgery, you know, after like a hip replacement or a brain tumor removal, it can take often just a few days or a week or so for the patient to go home. And once they're home, they're maybe still in touch with the healthcare system, but through digital means. So this has a lot of advantages, both for the patient, because for the patient, it's usually better to be cared for at home rather than at the hospital. People prefer to be at home often. And also it's better for the hospital because hospital beds are expensive, right? Thousands of dollars per night can be. So hospitals, health insurance, health ministries, they all want to reach patients through digital technologies, and they're really expanding. So there are smartwatches that count your steps and save money on your insurance premium. There are, of course, electronic health records, which are getting more and more complex, turning into big telehealth platforms. There's really sophisticated forms of remote surgery. There are apps which let you consult a doctor or even order medication from your smartphone and so on. So healthcare is really changing through digitalization, and the term for this is digital health. And so yeah, you may question, why is this happening? And yeah, as I said, this is really related to the process of ambulantization. And if chaplains, if spiritual care wants to continue being part of healthcare, they have to face a situation or a hospital which looks like the photos you're seeing here on the left, right? So chaplains can no longer walk through the wards, knock on doors, say hello to the patient. They can still do that, but the patient may only be there a very short time, not enough time to really build a relationship and talk with them. And more patients, they may not even come into the hospital anymore. They may just walk in, walk out, be treated in an ambulatory setting, and staff more and more sitting in front of screens like we are now today. So this is the new reality that spiritual care providers have to face if they want to continue being part of the healthcare system. So you can probably imagine how this move towards outpatient and ambulatory care and these digital forms of care delivery can increase the time patients spend alone, right? And particularly if they're not well cared for by friends or relatives at home. So the more time you spend at home, if you don't have a strong social network or family, a partner who looks after you, you may be very alone. In Switzerland, we have a service called Spitex, which is basically they come to your home and care for you at home. They do basically a home care service. And these may be the only people, some especially elderly people, these may be some of the only few contacts that some of the patients have. And this can be very isolating and can be really detrimental to mental health. Especially if a person is dealing with grief, with fear, with uncertainty, with existential experiences. Being treated in ambulatory care has many advantages, but it also means that if we're not careful about it, these people may fall into a hole, so to speak, right? So there's also the isolation of the provider, the chaplain, who through this digitalization, if you don't keep up with it, they may be cut off from the patients and also may be unplugged from the healthcare system. So as an example of this is electronic health records, which are really quite complex to use. And some chaplains don't even have access to these systems. If they do have access to them, they may not know how to use them. Some of these electronic health record systems are connected with software pieces which allows you to directly have a video call with a patient, for example. So chaplains need to know how to use these technologies or they have a big problem, right? They're basically otherwise left out from the clinical workflows and left out from their opportunity to care for a patient. So Scott Fitzgerald puts a word to this loneliness. So the loneliness moment is in someone's life, he wrote, is when a person is watching the whole world fall apart and all they can do is stare blankly. So this is the experience a serious diagnosis can bring. It can be what an accident can bring. It can be what death can bring. And it is exactly the moment spiritual care exists for, and exactly the moment that is hardest to reach when a patient is at home and at the other end of an electronic device. So spiritual care providers are there when patients' worlds are falling apart. And the question is, how can they continue to do that if healthcare is happening digitally so much? So prevalence of loneliness is an interesting one. It's not rare or confined to the sick. So there's a meta-analysis across over 100 countries, which show that between 9 and 14% of adolescents had experiences of loneliness. And this is rising in older groups as well. And of course, especially elderly people. If many of their friends and family have passed away, and especially men as well, who may be less socially integrated, this can be a really, really big challenge. So digital spiritual care is really the response of professional spiritual care to digital health. And just like healthcare providers are using tools to deliver medical care at a distance, so do chaplains engage with them to provide spiritual care. There is a term for this. It's called telechaplaincy. And it's basically analogous to telehealth. So tele here means basically distance, so healthcare at a distance. Telechaplaincy is chaplaincy at a distance. And this started as telephone care. This is quite well established as in many countries. As far as 2019, there were there was a national survey by Sprick et al. In the US, which found that more than half of chaplains in healthcare institutions had already used telechaplaincy in some form. And over the last 15 years, this term telechaplaincy has widened to cover the whole range of digital information communication technology. So borrowing on the World Health Organization's framing of telehealth, I describe telechaplaincy as care in which patient and provider are separated by distance, and use technology to assess spiritual needs, address distress, and document and evaluate their work. So what is new is that this is becoming a distinct professional identity. So these are spiritual care providers who specialize in remote care and are really redefining their role around the platforms they use. And I have called this telechaplaincy 2.0, which really marks the jump from old phone-based communication or care to these spiritual care forms in highly digital care settings. So in the US, you already have some job titles appearing at large health systems, which show this transition of the field. So you have like institutions with a director of on-demand spiritual care, or a director of spiritual care innovation and transformation, or you have a manager for innovation and spiritual care. And what these roles share in common is that they treat hybrid and outpatient care as a chance to make care more centered on what patients need and where they are. So this is what it can look like. This is one particular telechaplain sitting on a wall of screens, as we've seen before. And at this particular institution's patients are cared for entirely in their own homes through digital applications. So Mercy Virtual, as the name suggests, is really a digital-first hospital of the kind I think we'll see more in the future. And this chaplain does his whole job through video calls from this bank of monitors. And he never meets the patients in person, as it traditionally has been done. So let me illustrate how telechaplaincy can work with a couple of cases. So there's one telechaplain colleague of mine named Jane Joyland. She worked at the Yale New Haven Hospital in oncology, palliative and outpatient care, and she presented her experience at a conference we did on telechaplaincy in 2023. And she describes how her old way of working as a chaplain. She called it a physician-centered. So patients arrived after examinations and long journeys. There was very little space, and at the clinic, her conversations got squeezed into interruptions and bottlenecks. Phone calls were, drowned out by noise, and video calls were not possible because there was no privacy. And really, her contact with patients wasn't very good because of that. And she really started questioning her role as a spiritual care provider in this kind of clinical setting. And then the clinic moved spiritual care into a digital, or maybe a hybrid digital model. And she says through that, the patients became the main focus of her work. So she refocused her care around the patient's needs rather than the physical constraints of the clinic. So a nurse or a social worker did an initial assessment. People with spiritual needs were flagged in the software they used, and then referred the patient straight to her as a chaplain. And then she would call and follow up by phone or by video call every 1 to 4 weeks. And so none of this required travel. Patients were spared the pain, the cost, the exhaustion of getting to the hospital. She described giving these patients a safe hour in a safe space, and over months as well, real relationships formed in a way which couldn't have possible in this in this clinical setting where space and time was very compressed. And she actually ended up with more requests than she could handle as a telechaplain, and her self-doubt fell away. And And I think this is a really interesting case because it pushes back against this assumption that technology makes people lonely or isolated, right? Actually, she found the opposite, that moving her work into this digital care setting actually allowed her to connect more deeply with her patients and also over longer periods of time. So another case here is Baylor Scotland White Health in Texas. This is one of the largest nonprofit health systems in the United States with more than 50 hospitals. So here, telechaplains started working with the IT department to build spiritual care into the tools patients already used, were given by the health system. So the health system had this app called My BSW Health. And this app does the usual things. Patients can view results, even pick a doctor, make an appointment, book a video visit. But since January 2022, this app also has a feature called community support, which began actually as a prayer wall, and then they renamed it to community support. So this works like this, that patients post on this community wall, and they do it anonymously. And they share what they are going through, and they may ask for prayer or just share their concerns and feelings. And then they have a team of 150 to 175 spiritual care staff at this whole health system, and they all take turns moderating this community support feature. So they answer requests, they also watch for signs of suicidality, they remove anything that exposes confidential patient data, and they refer patients if there's a need for it or an emergency. So in the first month, they actually had 33,000 visitors to this app, which is much more than they expected. And the latest that I heard from them was that they had 15,000 visitors a month. And the interesting here is that the chaplains did not build this system alone, but they started actually out in 2017, so even before the COVID-19 pandemic, by cooperating with the digital health team of the Baylor Scotland White, and worked with the marketing team, and were backed by the senior leadership who really wanted to integrate spiritual care into their digital care delivery. And the demand has been so strong that no one actually was cut. There are no staff that were cut to pay for this. In fact, the system added the demand for new chaplains. So it created new demand rather than reducing demand. Often the idea is that digitalization reduces demand for human care. Actually, it increased. And I think also this is a really wonderful example of how professional isolation can be overcome by chaplains. So back to Switzerland, in the canton of Zurich, if you include telephone-based professional care, 11.2% of the population has had some experience of digital spiritual care. Compare that with the 2.8% nationally who reported having received this in a healthcare setting, and 5.1% in Zurich who received spiritual care, digital care in any context. So experience with digital media for spiritual or religious purposes more generally sits between 4 and 11% in Switzerland, which is well below the United States, where it is between 7 and 30%. Keep in mind that in healthcare, even very low percentage numbers can have a big impact, right? So on the demand side, 26.3% of Zurich population respondent said that it was important or very important that spiritual care is available digitally as well, which also lines up with about 25% who said so in a national survey. So basically about a quarter of the Swiss population want to have digital healthcare systems to integrate spiritual care in some way. And the question is really whether digital forms of spiritual care will feel like care to these people. And that is really the first question that I try to answer with a study which I'm presenting here now. But first I want to widen the frame a bit, because video calls and apps are only the beginning of the digitalization of healthcare. So here you can see some care bots. So these are robots designed to assist and keep company with people who need care. And a lot of this development is happening in Japan, where aging population and staff shortages are really major problems, especially in nursing homes. This development has been going on for a long time. So some decades now that care robots are being developed. Some are meant to just lift patients or fetch things for patients, but others are meant to talk, to be present, to reduce loneliness. And really the moment a machine is offered to as a company rather than a tool, we are in spiritual care territory. So CareBots are still a few years away from becoming truly mainstream, but there's already now a large market in AI companions that offer a relationship. So someone to talk to confide in, to be comforted by, and these are the AI companions. And I was just at the European Academy of Religion in Rome last week, and there one of the keynotes was Paolo Benanti, one of the Pope's advisors on AI, and he gave a talk, and at the end of his talk, he also answered a question and mentioned AI companions. And he called it the fast food of relationships. So engineered to be, satisfying in the moment, it's very cheap, it's always available, but over the long term, it's not very good for you. So I think it's an interesting metaphor. Whether he is right or not is an open question. I think should be answered with evidence. Of course, you could also say it's a theological and ethical or moral question. But in healthcare, evidence matters. And look forward to seeing how the evidence plays out on this claim. So there are also grief bots. So there are different types of grief bots. You may say there are a type of AI companions, perhaps. Some of them are chatbots trained on a deceased person's messages, voices, and habits. So the bereaved can go talk into a version of them. So there are already many companies that sell this. And of course, grief, death, and dying are often at the heart of what spiritual care tends to. And when a widow can open an app and hear her husband answer, the chaplain may really be challenged in how to respond to this. Is this helping the patient feel less lonely, or is it deeply meaningful for this patient, or is this potentially dangerous, or perhaps needs referral to a psychiatrist? There are also many different kinds of these apps. Some of them really try to create the digital avatar of a deceased person. Others have kind of more modest claims. In any case, we can see how spiritual care in the future may no longer be the only one in the room of offering to help make meaning of loss. And actually, I was just at the European Academy of Religion conference, as I said last week, and there was I believe she was an anesthesiologist, perhaps, in one of the panels, and said shared a story of having had a patient who was talking to ChatGPT to this person's deceased partner, I believe. And they actually took away this person's phone, and because they consider this to be a kind of a psychotic experience. So this is already becoming reality, really. Here's a short clip. I will skip that now. I will recommend you to watch on CNN or on YouTube this CNN video of a man who says ChatGPT sparked a spiritual awakening. It's quite interesting that when people go into intensive conversations with ChatGPT, because ChatGPT and other AI systems reinforce your existing beliefs, and they're very sycophantic. and they adopt your existing meaning framework. When this circles too long, it can really become disillusional, and it can also have kind of spiritual connotations, in the sense that there's an implication that the chatbot is giving access to a spiritual dimension of reality, or a hidden or transcendental dimension of reality, or maybe that the user in some way is spiritually special, or the chatbot itself. There are many kind of anecdotes of these things, and the whole dependency and loss of reality can be quite severe. And there's even a term now for this, as AI psychosis, and a self-help group as well, of people who have really become dependent in a very unhealthy way on chatbots. And of course, that also is for them then a way to make meaning of life. So the next, excuse me. Okay. So now to the study I wanted to share. So this is, I wanted to ask whether people actually accept digital spiritual care, and who is more inclined to do so. So we asked 3 things. This is a survey of Swiss population, population of Zurich, representative survey of the population of Zurich. We asked what experience does the population of Zurich have with digital spiritual care? Are people prepared to accept it? And which characteristics predict who accepts it and who does not? So this was we measured acceptance both looking back and looking forward, using a 2-phase mixed methods design. So first a structured questionnaire in German. We ran it in May 24. This was rather the beginning of the current AI hype. And as I said, a representative sample, just over 1,000 people. And then we also did 12 semi-structured interviews with people, which we chose deliberately across a range of experience and acceptance of and with spiritual care. So we divided the survey questions into 2 groups: previous experience with digital spiritual care and acceptance of digital spiritual care. And we calculated an index based on these questions. And a linear regression model then was calculated to determine the effects of the socio-demographic variables, religious and spiritual self-assessment, and the experience index on the acceptance of digital spiritual care. So in the interviews, we showed people 3 real models of digital spiritual care and asked them to imagine, using each of these examples, as a patient, as a relative, and as a healthcare professional, during or after serious illness, how they would feel about these digital spiritual care services. And we coded what they said for how useful they found each model and why, and what they saw as its advantages and drawbacks, and anything else they wanted to share. So this was the first model. This is basically an anonymous chat service, which was piloting in northern Germany at the time. This was presented as a supplemental model. Basically, if you're in a hospital, you can scan a QR code and anonymously chat with a spiritual care provider. Then we showed this platform here, which was being developed at the time at 2 hospitals in Basel in Switzerland, which basically is hybrid in a way that you can book an appointment with a chaplain for an in-person visit, and also you have on-demand resources for self-care. And then we also showed this, James Austin. You already saw him before, and we showed him as a kind of a model of basically digital-first spiritual care, where the patient only talks through digital means, like we can see here with all these screens. So here you can see the sample descriptive statistics for the whole sample. As I said, it was representative of Zurich. And here you can see the different types. So we divided the answers into types, the patients into types. So those who have had little or no acceptance with digital spiritual care and have a low acceptance score, we called skeptics, for example. And you can also see the distribution for people who have had little or no experience but are accepting, and we call them optimists. And you can also see people who have had experience but low rates of acceptance, whom we call disappointed. And lastly, those who have had experience with digital spiritual care and are accepting, and we call them converts. And yes, the regression model really showed that the strongest driver of acceptance turns out to be practical engagement. So whether someone has already had experience is really the largest driver of acceptance. Age is another predictor. That's not that surprising. Older people are less likely to accept it. But what is striking is really what doesn't matter. So gender and education had no significant effect on acceptance. And neither does self-rated religiosity, spirituality, or religious affiliation. So whether someone calls themselves religious tells you almost nothing about whether they will accept digital spiritual care. And that surprises people, and it really should reshape how we think about who these services are for. So here you can see some sample quotes from skeptics. You can see they worried most about losing the human element. So for them, the screen is where connection is threatened, and no feature list reassures them. And their objection is not really technical, it's about presence, right? Then the optimists, high acceptance without much direct experience, were the ones who reasoned in terms of fit. So different models suited different situations. So chat was okay for quick contacts, video for deeper calls, bookings for someone who wants, or you can also, book someone for an in-person talk for other conversations. So this kind of more nuanced, optimists had a more kind of case-specific understanding of, this could be good for this, could be good for this. Then the disappointed group are people with experience whose acceptance is low, and their reasons are specific. So they may have had experience where the contact with a care provider felt superficial, or when they wanted to talk to a person, but they just ended up with some digital thing which they didn't like. And then in the end, converts. So these are people who tried digital spiritual care and liked it. And so there are not that many of them, but they value the convenience and being able to reach care on their own terms. But they were also clear that it should be a complement and a support, not a substitute. So just to summarize this study, we could say that the numbers are low but concentrated in experience. So digital care is more common among people receiving outpatient treatment, which is a growing group. And on acceptance, a quarter of people want it, but their attitude swings really sharply depending on the model and the channel on offer. And patients are fairly open to this, but providers, so chaplains themselves, are much more conservative. So we also did a survey of chaplains in Switzerland, which really showed that the profession is much more cautious than the public in terms of digital tools. And this is a gap I want to focus on a bit more now in this next study on AI. So as part of healthcare, spiritual care, really encounters AI in the clinic more and more. AI systems are being used in clinical settings for many different purposes, from radiology to recording patient conversations to generate electronic health records. And spiritual care providers are really confronted with this situation and need to deal with it appropriately. And the point of this, or the idea of this question, of this study, was really to find out how experts assess the current and the future role of AI in spiritual care in different fields. So in terms of which tasks can be supported or replaced by spiritual care, what benefits and risks do they see, what are the theological and ethical concerns, what may be the appropriate limits on the professional competencies for spiritual care providers to deal with this rise of AI in healthcare. We also want to know whether these expert opinions varied across different professional and demographic subgroups. So this was a Delphi method. Delphi is a structured way to find group consensus through several rounds of anonymous and controlled expert feedback. It is a really wonderful method to find out what a group of experts thinks about a specific topic without having it be influenced by political dynamics. So this is used very much in healthcare to develop guidelines, for example, or just to assess the expert consensus on a topic. So you can see here, the gender split was fairly even. Most experts were in their 40s. And on affiliation, mainline Protestants were the largest group, but actually religious affiliation had no effect on the results. And by role, the two biggest groups were chaplains and professors. So we had a broad mixed panels of practitioners and academics, spiritual care providers, ethicists, theologians, and so on. So if you look at what they said, we can see here a summary of the second round of this Delphi study. The consensus here, there were 83 participants in round 2. And we wanted to know what experts thought are the capabilities of AI now and in the future. So what do they think AI is able to do now and in the future? Not what it should do, but what it is able to do now or potentially in the future. And we also asked to distinguish between whether AI is able to assist or to support with a task, or again, replace a person entirely. So this was a very large questionnaire with, in the end, 217 items. And these are just very few of them to give you an insight. So one representative item for the highest ranking strong agreement, median, moderate, and lowest ranking disagreement items. And so you can see here, there's really strong agreement in the professional community that AI right now is able to support providers' understanding, but cannot replace human wisdom, empathy, or discernment. But there's also moderate agreement that it can contribute through generative creative works that shed light on these themes through the generation of creative works. So quite interesting here that the expert panel agreed that the, say, human relational core should be preserved of spiritual care, but there are many other tasks which the experts moderately or strongly agreed could be supported by or even replaced by AI systems. So if you look at the future, the experts strongly agreed that AI will be able to reveal patterns in patient narratives of suffering, mortality, and sacredness. And if you look at the capability of AI to assist with or enhance the work of spiritual care providers, we see a strong agreement that AI already apparently is able to perform administrative and routine tasks, such as scheduling patients, recommending follow-ups, producing reports. And there's also moderate agreement that AI can assist with or enhance with legacy tasks and advanced directives, such as writing ethical wills, life reviews, farewell letters based on patient inputs, and so on. So this is This gets more contentious when we see that there is also a moderate agreement that in the future AI is assessed to be capable of assisting or enhancing direct patient agreement, direct patient engagement in the future, right? And it's also food for thought, because some of these tasks which seem administrative, like producing reports, actually still require human discernment. But they may seem like administrative and routine, but in practice, they may actually still require quite a bit of human discernment. Risks and benefits, you can see here, potential benefits, most highly ranked, improving screening and triage. Again, an example of something which is very routine in clinical settings, can be done automated even, but still requires human discernment in a way, because humans have so much more context and understanding of things than a standardized system or automated system can have at this point. Then about half of people, just below half of people in this panel actually think that the benefits outweigh the risks of having AI in spiritual care settings. Then there are quite a few theological and ethical considerations. The interesting thing here is that the experts agreed that there need to be limits, professional limits of how AI can be used, but the reasons for that quite different. So the theological and ethical considerations did not have very high levels of agreement in comparison with the items on whether there should be limits or not. So this can be called incompletely theorized agreement, right? Where there is an agreement that something should be done, but it's not quite clear for what reasons we agree on that. There are also competencies which spiritual care providers need to have to judge AI and to appropriately use AI or not use it in spiritual care settings. And the most highly ranked competency is the ability to judge AI applicability and boundaries. So knowing when AI is appropriate and when it is not appropriate. And this, of course, is something many of us are figuring out. When it is appropriate to use AI, when is it not appropriate to use AI? And this also needs to be figured out for spiritual care in clinical settings. Subgroup analysis, very briefly, is interesting to see that subgroups did not really significantly determine almost any of the findings. So profession, age, gender, religion, none of these really made a difference. There were a few couple of very small differences between European and North American respondents and how they answered. But basically, you can say this international panel broadly is on the same page in a way, that there are not, say, the Americans had a totally different idea, or women had totally different idea, or Catholics had totally different ideas. So this is good foundation for a professional consensus. Yeah, so very briefly, some few thoughts. So it's AI in spiritual care is not really a simple for or against issue. It's very task specific. There are many different tasks where AI may seem appropriate, but then a closer look, it's more complex. There are other tasks where it is very debatable. It's also interesting that their acceptance of AI and spiritual care is higher with regards to the future capabilities. So the experts assume these systems to improve. And in some ways, some of these opinions don't seem to rest on theological arguments on principles, just on the assessment of whether the technology is at right now. So some of these reservations will probably disappear as these technologies improve. And yes, the other 2 points I've already discussed. I'm coming towards the end of my time. I just want to lose a few words on this point of professional isolation. So as I have said before, this notion of spiritual care providers being unplugged So we have talked about patient loneliness, patients being unplugged from providers or being connected through them through digital media. Because healthcare is becoming digitalizing so fast, and through the use of AI, this has accelerated even more. Spiritual care providers may really feel left out and left behind and isolated in a sense. As one of the few or maybe last professions in a hospital which is not fully integrated into digital infrastructure. It is easy to imagine how this can feel isolating and how detrimental this is actually to a profession like spiritual care. And there are regional differences in how acute this professional isolation is. I think in the US, chaplains are generally much better integrated with digital health. In Europe, it is less, as far as I can see. We have launched a project called the Telechaplaincy Community of Practice. And the idea here really is to plug people back in. So to connect practitioners and researchers and department heads or leaders of spiritual care departments, who are all dealing with the same challenges of digitalization in spiritual care, and really connect them in a community of practice to figure out how they together can bring their professional community into this new digital era of healthcare. And this community of practice has grown within a few years very quickly. It is over 350 members now. And it really shows that there is a big demand on one hand for professionals to engage with this digitalization, but also on the other hand for them to connect with each other and overcome their own sense of professional isolation. Yes, this is all I think for now. Please visit my website and send me an email if you're interested to learn more, and I look forward to our discussion. Thank you.